Hello everyone, my name is Dr. Mayur Agrawal. Welcome to another session of MCQ discussion. Today we'll be discussing about NEET SS Endocrinology recall. These are not the exact questions. This is the recall and we'll be discussing about this. So let's begin. Our first question here is not a feature of primary adrenal insufficiency. So which of these is not seen with Addison's disease? Hyponatremia, hyperkalemia, hypercalcemia or eosinopenia. Okay, so this question we have already discussed in question number 24 when we are discussing about adrenal. So this is very basic here. We know that in primary adrenal insufficiency or Addison's, there is deficiency of cortisol as well as aldosterone, both mineralocorticoid. So this, when there is mineralocorticoid deficiency, what does this mineralocorticoid do? This actually increases the sodium and decreases potassium, that is conservation of sodium, decreases sodium excretion. So when there is deficiency of this in Addison's, what will happen? This sodium will decrease and this potassium will increase. Okay, so we have here hyponatremia and hyperkalemia. This will be seen with Addison's. Now coming to hypercalcemia and eosinopenia. See, in this Addison, what is there? That volume is low, hypovolumic state, EGFR is less. So in compensation, there is renal conservation. So what happens? That there is increase in BUN and increase in calcium. So up to 6% of the patients with Addison's will have hypercalcemia. Okay. In fact, if you see a patient of Addison's with hypocalcemia, that is the calcium is less, then you have to think about APS. Okay, so in APS 1 there would be hypocalcemia with Addison's. And coming to our last option, eosinopenia. So this eosinopenia, we know that there is diurnal rhythm with the cortisol. The cortisol is higher in the morning. At that time, the eosinophil count is less. This has been asked various times, that eosinophil count is less in morning. Why so? It is because of the diurnal rhythm of the cortisol. Okay, so when this is deficient, there would be increase, right? So these patients don't have eosinopenia. These will have eosinophilia. Okay, so this is the right answer for our first question. Okay, coming to our second question, the CVOT trial does not include, which of these does not is not a CVOT trial for DPP4 inhibitors? So we have option here, Carmelina, Leader and Examine. Okay, so these, when I was discussing diabetes, question number 42, I have told you regarding this, that trials name at least you should remember. So this is just like one-liner factual question. So you see here, this I have taken from ADA. So these DPP4 trials are important. Examine is for allogliptin, TICOS is for sitagliptin, Carmelina and Carolina, these are for linagliptin. So these trial you should remember for DPP4 inhibitor. And important SGLT2 inhibitor trials, EMPA-REG is very important, CANVAS for canagliflozin, EMPA-REG for empagliflozin, DECLARE, TIMI for dapagliflozin and Credence for canagliflozin. So these are important. Then recently Emperor for empagliflozin and DAPA-HF for dapagliflozin. So these trials are important trials of SGLT2 inhibitor. Then we have GLP-1 analog, glucagon-like peptide 1 analogs. These trials are these you can just remember 2-3 trials which are important. Leader trial for liraglutide, then Sustain 6 for semaglutide. That semaglutide is subcutaneous semaglutide. For oral semaglutide, we have trial Pioneer. So this would definitely be asked. This is the most recent thing. Pioneer trial for oral semaglutide. That is really important. Then Rewind trial for dulaglutide. So these are some very important trial which you should remember, at least name. If you don't know what is there, just remember the name. Okay. So coming to our next question. which is peculiar for Cushing's, whether it is facial plethora, buffalo hump, central obesity, or weight gain. So these again question I have discussed when I was discussing adrenal, question number 7. So these are discriminatory factor. There are various clinical features in Cushing's, but which can discriminate that this is more probably a Cushing's patient. Which of these have a higher sensitivity that if this is present, then this patient would be having Cushing's. So the answer here is facial plethora. Obviously buffalo hump, central obesity, weight gain, all these are also features of Cushing's, but discrimination. Okay, so that facial plethora has a higher discriminatory index for Cushing's. If they have asked about the most common feature of Cushing, then it would be weight gain, but they have asked which is peculiar, that means discriminatory. So that is facial plethora. These I have taken from JCM guideline 2008. You can see here that these 4 features is easy bruisability, facial plethora, then proximal myopathy and striae. These have a higher discriminatory index for Cushing's, and in children, if the child is gaining weight but not gaining height in proportion to weight, then probably this patient is having Cushing. That is also very, very important. So in adults, a higher discriminatory index for Cushing's is easy bruisability, facial plethora, myopathy and striae. But if they want to make this question further tough, okay, so they can ask you, they can give you these options as well, that all these discriminatory, which is the best one. So the best one is easy bruisability would be the best one, followed by myopathy, followed by facial plethora, followed by striae. So in all these 4, this is not given in guideline, this is from a article which was published in Lancet. So the most discriminatory would be easy bruisability, but we have the option of facial plethora here, so that is the answer. Okay, so these features are there, but peculiar would be facial. And you see here that all the like obesity and all those features are of Cushing, you know all those things. Coming to question number 4, obese male with recent ACS, which is to be added after metformin. Okay, so empagliflozin, acarbose or linagliptin. This also we have discussed when we were discussing question number 30 of diabetes. This is based on guideline, the ADA. Okay, so this is the chart. We know that everybody of you must have seen. So what is the first line treatment for diabetes? It's obviously lifestyle and metformin. So see, if it is not controlled after metformin and lifestyle, then you will see other features, and depending on it, we decide that which drug should be given after this. So clearly the question mentions here that the patient has ACS. So if the patient has this ASCVD, atherosclerotic cardiovascular disease, then you should give him SGLT2 inhibitor or GLP-1 analog. But if the sugars are not controlled with one, then add the other. That means if you are already given a GLT2 inhibitor, sugars are uncontrolled, then you will add on GLP-1 analog. If you have given GLP-1 analog, sugars are not controlled, you will add SGLT2 inhibitors. But the problem with GLP-1 analogs, till now, most of them were injectable. But now we have oral GLP-1 analog also. Okay, so this is the thing, GLP-1 and SGLT2 are the preferred. But if the patient has heart failure, our patient has ACS, then obviously the answer in this question would be empagliflozin, which is an SGLT2 inhibitor. Okay, so if the patient had heart failure, then even over GLP-1 analog, you would prefer a SGLT2 inhibitor. Okay, so if the patient has heart failure, you will give him SGLT2 inhibitor. If the patient have CKD, that is DKD, if the patient has proteinuria, microalbuminuria, then you can give SGLT2 inhibitor or GLP-1 analog. Okay, Similarly, all these you must know that if the patient has a weight gain, then you would prefer a GLP-1 analog or a SGLT2 inhibitor when you want your patient to lose weight. If cost is a major issue, then sulfonylurea and pioglitazone are the preferred one. But now even this SGLT2 inhibitors are costing very less. You can get for like say 10-11 rupees per tablet. If hypoglycemia is a major concern in your patient, then after metformin you can add any of the following: DPP4 inhibitor, GLP-1 analog, SGLT2 inhibitor, or pioglitazone. Okay, sulfonylureas will cause a higher hypoglycemia, so all those things you must know. Okay, let's move on to next question. Question number 5, not associated with rickets. So whether it is RTA, hypoparathyroid, or hypophosphorus. Okay, so renal tubular acidosis, we know that it is associated. Hypoparathyroid is not at all associated with rickets. So when we are discussing bone in question number 42, I have discussed everything about rickets. So this is the same chart. I have given a question that which is one single investigation which would you do in a patient of rickets. That's obviously an X-ray, you can diagnose on that. If a biochemical, then it would be an alkaline phosphatase. Okay, so alkaline phosphatase you see, an X-ray you see, and you can diagnose the patient that the patient has rickets. After that, you want to have PTH, phosphate and calcium, and basically broadly they have divided into two, whether it is calcipenic or phosphopenic. So calcipenic will have a normal calcium or a low calcium with a high PTH. That is what a nutritional ricket, that is what most of the rickets patient we see that will fit into this. Then we have phosphopenic rickets. Okay, all those X-linked, FGF23, all those things. Okay, so here the PTH would be normal or elevated with a low phosphate with a normal calcium. Okay, so these are basically two types. So in rickets you will have PTH high. So this hypoparathyroid is absolutely wrong, not associated with rickets. The answer is B. Coming to question number 6. Okay, so this one is really a good question here. Low vitamin D, 25 hydroxy vitamin D, with low normal 125 vitamin D, with high PTH, with high ALP, with normal calcium, normal phosphate, and no response to vitamin D since 6 months. So what is your diagnosis? Okay, so here first let's solve step by step. We have here low vitamin D. It can be anything, nutritional, right, or something. Then low normal 125 vitamin D is still, it can be anything. High PTH is still, it can be anything. High ALP, it can be anything. Then normal calcium and normal phosphate. The clue here is patient not responding since 6 months, but they have not given the dose, but we consider that it is an optimal treatment. If they would have given alopecia in the question, the answer would be directly it would be a VDDR type 2 if alopecia was given. But alopecia they have not mentioned. So let's see what is this 1 alpha VDR1 and VDR1AB. Okay, so see here, VDDR1, actually now there are 3 types, recently 3rd type is also there. So here there is defect in the hydroxylation of the vitamin. 1 alpha hydroxylation defect is type 1A. 25 hydroxylation defect is VDDR1B. If there is receptor defect, it is 2. And then there is HNRNPC defect, which actually metabolizes this receptor sort of thing, you can understand. So this is VDDR2. Then there is inactivation of the vitamin D by 24 hydroxylase, which is again VDDR3. So these are 3 types of VDDR. Okay, now coming back to our question, what we have here is a low 25 hydroxy vitamin D and a low normal 125. That means the defect is at 25 hydroxylation, because you are giving him vitamin D, is still there is low 25 hydroxy vitamin D. Okay, so answer here would be 1B. But actually in question they have not mentioned that whether this profile, whatever this biochemistry they have given, this was before replacement or after replacement, but we do consider that it is mainly after replacement. So the answer would be 1B. If they have not mentioned this, and if they want a tougher question, then, and even if you just miss this line, no response to vitamin D, just if the question have mentioned low vitamin D with no normal 125, with high PTH, high ALP, with normal calcium, normal phosphate, that can be just a nutritional rickets, or VDDR1, 2, anything can be there. Okay, so this line is very important, and if you see alopecia in the question, you can directly mark VDDR2. Even whatever the biochemistry, they are basically pointing you towards VDDR2. Okay, so this we have discussed in detail previously also. Coming to question number 7. Not used in pheochromocytoma for hypertension. Alpha blocker, beta blocker, calcium channel blocker, or diuretic. Okay, so see, this is also like can be a tricky question here, but obviously it's a direct question here, so you would mark a diuretic. Usually we don't give in pheochromocytoma because they are already volume depleted. That is why they have orthostatic hypotension, right? Some of the patient may have, usually there is hypertension, but some of the patient can have orthostatic hypotension. That is because of the volume depletion. So in this volume depleted patient, you don't want to give diuretic. Okay, so coming to alpha blocker is obviously what we give. Beta blocker should not be given till the patient is adequately blocked by an alpha blocker. So if the question was like initially contraindicated in pheochromocytoma, the answer would come beta blocker, but it's just in line, because see, this is not the exact question, this is recall, so you have to read each and every word. Even a single word would change your answer here. So not used in pheochromocytoma, diuretics are usually not given. CCB and alpha blockers are given, and after the patient is adequately blocked by an alpha blocker, then only we introduce the beta blocker. So this is from Williams latest edition, 14th edition. There are IV drugs, there are oral drugs. We know that alpha blocker, phenoxybenzamine, prazosin and doxazocin, these are commonly used. Then labetalol, nicardipine. Okay, and IV phentolamine is usually used. Nitroprusside is also used in crisis. So all these things, you know that they are used. Okay, coming to question number 8. False about GLP-1 agonist. They improve the glycemic control, increase colon transit time, delays gastric emptying, cause significant nausea and vomiting. So this also we have discussed when we are discussing these questions. So GLP-1 analog, you know that how does it act? It will obviously improve the glycemic control, it delays the gastric emptying, and the major side effect I've already told you is nausea and vomiting, right? So the answer here is increase in colon transit time. There are some few papers I was going through. Actually, this is not directly written in Williams or your Harrison, but when I was searching for all the option, I could find a paper in which there was a study on type 1 DM, which showed that this colon transit is accelerated by this GLP-1 analog. That means there is decrease in transit time, but otherwise most of the paper and most of the literature, what they have mentioned is that it delays the gastric time and it delays the small intestine motility. But the option here is increase in colon transit time. Most of the papers doesn't mention the action of this GLP specifically on the colon, but other three options are really pretty easy. So the answer here is increase in colon transit time. Okay. Now coming to question number 9. incidentally detected calcium of 11, what is the next step? So we could not get the options here, but you know the basic thing I've already told you when I was discussing question number 16 in bone MCQ. So how to go about a raised calcium? First and most important thing is to reconfirm, because you cannot rely on just one value. It can go falsely wrong, and then all those tests will be just waste of the money and would cause so much like burden to the patient. So whenever you get a raised calcium, first and most important thing is to repeat the calcium. Get a ionic calcium. Also you get phosphate and alkaline phosphatase. Okay, so these are the first thing you should get. Then also it is very important how you take the sample. Ask the lab person not to tie the tonic weight, because when you tie the tonic weight, there is stasis, and this venous stasis can itself cause slight raise in calcium, and we want exact value, because then only we will decide that whether we need to proceed further or we have to stop it here. Okay, so once the calcium is raised, again I don't know what were the option. If the option was repeat calcium, then obviously that would go first. So get a ionic calcium or a repeat calcium, correct it for albumin, all those things. Okay, then what to do next is to get PTH level. In fact, intact PTH is what is recommended. At least second generation assay should be used. After you get a PTH, then only the algorithm should be followed, that whether it is a PTH dependent hypercalcemia or PTH independent hypercalcemia. The cutoff is 20 milligram. Okay, so this is the cutoff we use for this in intact PTH. So milligram per ml. Okay, so this, if it is more than this, then it is most likely it is PHPT, primary hyperparathyroidism, most probably an adenoma, or it can be a lithium induced, or it can be an FHH. We'll be discussing more about that later in MCQ. And if it is independent, that is if the IPTH is less than this, then you need to get vitamin D. This is very, very important, because now with so much of supplementation, like people are getting so much of this injectable vitamin D in 6 lakh unit, and they are getting it like monthly also. Okay, and we see these patients who have this vitamin D toxicity, and because of that they have hypercalcemia. Okay, one more important thing here, even when you get the calcium phosphate, then also you can just see, because if we are dealing with an raised PTH, then the calcium would be high and this phosphate would be low. But in vitamin D toxicity, the calcium would be high, also the phosphate would be high. So from there also we get some information. Then you get this vitamin D, PTH, RP is also related peptide. Okay, so this is then multiple myeloma should be ruled out. Okay, so all these are important things which we will look for. Then sarcoidosis, where there is activation of vitamin D from 25 to 125. There is a excess of activation by 1-alpha hydroxylation. So these are all causes of PTH independent hypercalcemia. So all these algorithm to be followed or not to be followed, this depends on whether you establish that there is hypercalcemia or not. So first would be to repeat an ionic calcium. Okay, coming to question number 10, not an example of specificity spillover. So this is very good question here. Galactorrhea with acromegaly, pigmentation in adrenal insufficiency, hypercalciuria with acromegaly, and IGF-2 mediated hypoglycemia. Okay, so first, what is this specificity spillover? You know that there is lock and key model. Every like hormone have a receptor, and it specifically binds to it and mediates the mechanism, whatever the receptor is there. But there is some hormones which have similarity, and some receptors which have their receptors are similar. So when one hormone is in excess, it can act on other receptor as well. This is what is called as specificity spillover. So in acromegaly, when you have very, very high growth hormone, what happens that this acts on the prolactin receptor and thereby it causes galactorrhea. So this is absolutely an example of specificity spillover. In fact, there can be in acromegaly galactorrhea because of a co-secreting tumor which will secrete prolactin and as well as growth hormone, or there can be specificity spillover, or just the tumor size which is compressing the infundibulum, that is why it is stopping that dopamine and thereby raising the prolactin. So these are the three basic mechanisms by which a patient of acromegaly can have galactorrhea. Then pigmentation in adrenal insufficiency. This is also an example of specificity spillover. So this MC1R receptor, when this ACTH is high in adrenal insufficiency, this acts on MC1R and cause pigmentation. Okay. Then coming to our fourth option, IGF-2 mediated hypoglycemia. This IGF-2 can act on the insulin receptors and can cause the hypoglycemia. In fact, we have seen few patients, especially with this liver carcinoma, they can secrete this IGF-2 and cause hypoglycemia. This is a rare presentation, but it can be there. So our answer is hypercalciuria with acromegaly. Actually, this mechanism is not absolutely clear that why is there hypercalciuria with acromegaly. Okay. So this is our answer for not an example of specificity spillover is option number 3, hypercalciuria with acromegaly. Okay. Coming to question number 11, low calcium, high phosphate, high PTH, high ALP, AHO absent and urine CMP low. What is your diagnosis? So see, this is like slightly tough to remember, I know that, but this chart we have discussed so many times. We have discussed this when I was discussing question number 41 in bone. So when you follow a stepwise thing, you can remember all these things. So let's start. First and foremost, you see whether what is the biochemistry. If calcium is normal, phosphate is normal, ALP is normal, only AHO phenotype is present, then the answer is pseudo-hypopara. Okay. So this you can easily mark. If they have given a normal biochemistry with the AHO phenotype, you mark it as PPHP, pseudo-hypopara. Okay. Now all other options will have biochemistry abnormal. Okay. If you have biochemistry abnormal, first see what is biochemistry abnormal in this. We know that if they've given here low calcium with high phosphate, that is hypopara. Okay. But they have given high PTH. That means it's not hypopara. The PTH is high. Still it is not acting. That means it's a case of pseudo-hypopara. Okay. So only by these three things we can establish that this is a patient of pseudo-hypopara. Now we have to subclassify that what type of it is. Okay. So if the calcium is low, phosphate is high and PTH is high, so this is pseudo-hypopara. If AHO phenotype is absent, okay, then you mark it as 2. Okay. See here. Pseudo-hypopara type 2, the AHO phenotype is not there. Okay. And if AHO phenotype is present, then you mark it as 1A. Okay. So AHO phenotype only without biochemistry is pseudo-hypopara. Biochemical abnormality with a AHO phenotype, then you have to mark 1A. Biochemical abnormality without AHO phenotype, it is 2 or 1B. Okay. Now how to differentiate between these? So you see here, that is response to urinary calcium and resistance to other hormones. So if it is there is no resistance to other hormone, then it is type 2, but if it is there, then it is 1b. And this, if urinary calcium response is normal, then it is 2. Okay, so this is how to go about. So we have here AHO is absent. Okay, so AHO absent is 1b or 2. Okay, that is what the chart says. So 1b or 2. These are, we have ruled out this, we have ruled out this. Now urine CMP low. That means we are dealing with 1b here. Okay, so this is how you have to remember. This is really tough, especially when you are answering the question in such short time. It becomes really confusing. Okay, so this I have taken from Drieg root. This is about the paternal imprinting. This is important, that from which the gene of this is coming, accordingly the phenotype would change. If the defective gene is from male, then the patient will develop pseudo-hypopara. But if the defective gene is from female, then the patient will develop pseudo-hypopara type 1A. In both these, AHO phenotype is there. That means that both the genes are important for bone development. Okay, so if this is inherited from a father, then pseudo-hypopara, the patient develops pseudo-hypopara. If it is inherited from the mother, the patient develops type 1A pseudo-hypopara. Okay, coming to question number 12. 30-year female with secondary amenorrhea, which of the following is not required? LH, FSH, USG pelvis, prolactin or testosterone? Okay, answer here actually depends on the clinical context, which is not given in question. We do get all these tests in a patient of secondary amenorrhea, and this is important. What the clinical setting is there, accordingly we will decide that which test should be done. Okay, but if you will follow this algorithm of Harrison latest edition, they first done a USG to see the outflow tract, uterus, and then if there is hyperandrogenism feature, they have taken testosterone also. Obviously will get it done, but in this question there was nothing like that given about the patient. So LH, FSH we do get, USG we do get, prolactin. Testosterone is slightly lower down in the algorithm. It depends if the patient have hyperandrogenism feature or not. Usually it is not required. First, actually I would say, what would you get first thing? If the patient has secondary amenorrhea, first let's discuss about definition. Secondary amenorrhea is if a patient have irregular menses already and no menses for 6 months, then it's secondary amenorrhea. If the patient have regular cycles previously and now does not have menses for 3 months, then you need to evaluate. They will be evaluated. So in this secondary amenorrhea, what is the first test you want to get? The first test would be pregnancy test. You need an beta HCG, either a UPT urinary pregnancy test or a beta HCG from the blood. You need it. That is the first test we should get in any patient who has secondary amenorrhea. Following that only you do all these things. Okay, and then you get a what is common should be done first, right? Then you get a thyroid function, because that can also cause this, and your prolactin can go falsely wrong, it can go high because of primary hypothyroidism. Because in primary hypothyroidism, the T3 T4 decreases, the TRH increases, that is how the TSH increases. This TRH will also act and will cause this prolactin to be raised. So you need to first rule out this primary hypoparathyroidism. Then primary hypothyroid you must rule out first before you do a prolactin level. Okay, so this is important. Now coming to a question number 13, hungry bone syndrome, which is not seen in this. Hypocalcemia, increased PTH, increased bone density, and hyperphosphatemia. So this also I have discussed when I was discussing question number 27 in bone. First let us talk about what is hungry bone syndrome. So when you operate a patient of PHPT, primary hyperparathyroidism, then this patient can develop hypocalcemia postoperatively. It can be either due to, because we have removed now PTH, then it can be due to hypoparathyroidism. Okay, then it can be due to hungry bone syndrome. So you can just diagnose on the basis of phosphate. See, it can be a hypoparathyroidism because the PTH is now removed. So what happens that calcium decreases, phosphate increases and ALP decreases. This is post-operative hypoparathyroidism. What happens in hungry bone syndrome? Because our patient was having so high level of PTH, his bone was giving calcium, that calcium from the bone was coming to the blood, right? Now this PTH we have removed. So again the bone will take up the calcium. So what happens? The calcium will decrease in hungry bone syndrome. But because there is bone formation, it will take up the calcium as well as the phosphate. So this phosphate will also decrease. And this ALP will increase. This is the basic of hungry bone syndrome. So calcium low, phosphate low with a high ALP is hungry bone syndrome. Low calcium with a high phosphate with a low ALP is post-operative hypoparathyroidism. Now sometimes people do ask, can this coexist like because now you have removed this and other glands, like even if you are removing an adenoma, single gland adenoma, other 3 glands would be suppressed because that single gland was producing too high PTH. But both usually doesn't exist, because for this hungry bone syndrome, for bone to be formed, at least some of the PTH is needed, right? So these two doesn't coexist actually. So now coming back to our question, hungry bone syndrome. Now, if you remember the basic thing that what is the mechanism, then only you will be able to answer all these questions. You cannot cram all these things. So hungry bone syndrome, hypocalcemia, obviously now bone is more forming, it will pick up the calcium, right? Increase in PTH, yes. Increase in bone density. Actually, I don't think this would be an option here, but yes, bone density would increase in because now bone is formed, but usually it is not so early that you can pick it up. Then hyperphosphatemia, obviously because the bones are now forming, so calcium and phosphate both are picked up. Patient won't have hyperphosphatemia, patient would have hypophosphatemia. Okay, that is important. Coming to question number 14, glucose is 35 with low insulin, with low C-peptide, with negative ketone, and glucose is increased by glucagon injection. What is your diagnosis? Okay, so all these things we have discussed in question number 68 of diabetes, that how to proceed for a patient with the hypoglycemia who is non-diabetic. This is important. See here, first, whether the patient has hypoglycemia or not, then only you can interpret. That's the critical sample that I have told you. So this glucose 35 is hypoglycemia. Now we have low insulin and low C-peptide. Even if you don't see further, you can just mark by this only, because see, now we have non-insulin dependent hypoglycemia. So regular of insulin use is ruled out. Sulfonylurea will act on the sulfonyl receptor and will secrete the insulin from pancreas. So this would be again a C-peptide high with an insulin high. It would be an insulin dependent hypoglycemia. So exogenous use of sulfonylurea is ruled out. Hirata disease, this is basically an autoimmune condition where you have antibodies towards insulin. So what happens that whenever the patient eats, okay, in the blood glucose raise, insulin is released, but now the antibody that actually chelates, that bounds to the insulin. So more insulin is released because still sugars are high. That insulin, whatever was released, was not enough because it got chelated with your antibodies. Now what happened after some time, what will happen, because this will stay in circulation. Now this is a bigger molecule, antibody with the insulin won't be secreted much, so it will remain in your blood, and gradually this will dissociate, and so you will have a higher insulin, because after dissociation this insulin which was bound to antibody will also act. So that is also an insulin dependent hypoglycemia. So our answer is IGF-2 mediated hypoglycemia. This is what. So just basic, I'll tell you few very clinically relevant, and question would be asked from this. Whenever you get a patient of suspected hypoglycemia, what is the first thing you need to remember is you have to confirm the Whipple's triad. What is Whipple's triad? That is documented hypoglycemia with the symptoms of hypoglycemia, and that resolves after taking sugar. Okay, so that symptoms should resolve. So these triad should be definitely satisfied, then only you proceed further. If Whipple's triad is not satisfied, you cannot label that like this is, you need not work up for hypoglycemia. Okay, and hypoglycemia in diabetic patient is totally different, and it is pretty easy. You have to just ask history, and even without getting any test, because usually like patient have taken wrong insulin, higher dose of insulin, patient was having some infection, missed meal, patient had vomiting, all those things we know that patient took some sulfonylurea, was not able to take the food. So like that is very common. So hypoglycemia in diabetic is totally different, and non-diabetic hypoglycemia needs thorough workup. Then first and foremost thing, after Whipple's triad, you have to see that what are the drugs. Is there any drug which can cause this hypoglycemia? Okay, alcohol, that is really important, so you have to rule out that. Then if the patient was in sepsis, has some cardiac disease, renal disease, or some liver disease, then hormone deficiency, Addison's will have hypoglycemia, so that is very important. Growth hormone usually does not causes hypoglycemia in adults. Okay, these deficiency usually does not cause. Then some mesenchyme tumor can cause hypoglycemia, and insulinoma you think about. Keep the common causes first, then only you work up for these all causes. Coming to this chart, this is very, very important. This I have taken from Williams. So see, first, if there is no sign and symptom of hypoglycemia, that means your Whipple's triad is not satisfied. No need to further work up, nothing to do. Just leave it. Okay. In all other condition, you have symptom signs, that is like Whipple's triad needs satisfaction. Okay, that is criteria should be fulfilled. Then glucose is low, documented hypoglycemia. First, let's see what happened to insulin. If insulin is less, then obviously it is insulin independent hypoglycemia, either it is IGF-1 or which was given in our option. Okay, so that it's pretty easy. Okay, now if insulin is high, then you see C-peptide. If insulin is high and C-peptide is low, what does that mean? Because in our body, insulin and C-peptide are secreted in equimolar concentration, 1:1. Okay, but if the patient has very high insulin and or a high insulin with a low C-peptide, that means that patient have taken insulin from outside. It can be a factitious hypoglycemia. So that is easy. If you have insulin high with a low C-peptide, that means it is exogenous insulin. Okay, even if you don't see further things also, just by if you will think like that stepwise, then only you will be able to remember all those things. Otherwise you cannot cram this chart. Okay, then insulin also high and C-peptide also high. Now you cannot say that it is because of, obviously it is endogenous hyperinsulinism, that is satisfied because C-peptide with insulin is endogenous. But whether this endogenous is due to insulinoma or because of some oral hypoglycemic agent which patient took, still it can be factitious, right? So for this you need screening, urine screen for sulfonylureas. Okay, then you can differentiate between these two. And if the insulin is very, very high with a C-peptide high, Okay, we take ratios, then it can be a Hirata syndrome, insulin, autoimmune. Okay, so these things are basic. You can proceed stepwise and answer this. So in our question, low insulin with a low C peptide will be a IGF-2 mediated hypoglycemia. Also, if there is insulin is present, ketones are negative. That is important, because if patient has this non insulin, but IGF-1 will act on that also, because then these patient will have less of ketones, don't have ketones. Okay, non insulin, non IGF-1 mediated hypoglycemia will have ketone positive. You know that insulin inhibits ketone synthesis. That's the basic here. Okay, so question number 15, we could not get exactly what was asked, but the recall said that imaging of polyostotic fibrous dysplasia with history of fractures. Coming to question number 16. Okay, so what is false about pheochromocytoma? 10% are malignant, 10% are familial, 10% are normotensive, and paroxysm has varied presentation from person to person, but stereotypical in individual. Okay, so these question I have already discussed when I was discussing adrenal, question number 6 and 12. So we know that 10% are malignant, 10% are bilateral, we know that, and 10% are extra adrenal. This we know. 10% are familial is absolutely wrong, as more and more genes are being discovered. Up to 40% of these pheochromocytoma are familial. Okay, 10% are normotensive. This I have told you, around 10 to 15% of the patient are normotensive, and even patient can have orthostatic hypotension, just we discussed. That is why diuretic should not be given. And paroxysm has varied presentation from person to person, but stereotypical in individual. This is a right. This is a exact line picked up from Williams. Okay, coming to question number 17, which is not a bone formation marker. Propeptide of type 1 procollagen, cross-linked N-terminal peptide, osteocalcin, or bone ALP. So these we have discussed in detail in question number 29 of bone discussion. So the answer here is cross-linked N-terminal peptide. All the rest of the three are bone formation marker, but this is bone resorption marker. So this is like just factual question. Coming to question number 18, in pregnancy, which of the following is wrong? First option we have thyroxine requirement increases as the placenta express type 3 deiodinase. TPO antibody will cross placenta but not affect fetus. Fetus to seen for tetany if mother have hyperparathyroidism, and dexamethasone cannot be used in pregnancy. Okay, so exact words we need for a correct answer, because I'll tell you why it is controversial here. Thyroxine requirement increases as placenta express type 3 deiodinase is absolutely right here. We know that up to say 25 to 50% we have to increase the dose of thyroxine. That is because of the placenta having deiodinase 3 activity increase. Also because increase in estrogen increases the TBG. That is why this T4 is bound more. Okay, so thyroxine requirement increases. That's the correct option. Coming first to option number C, fetus to seen for tetany if the mother have hyperparathyroidism is also right, because mothers who have hyperparathyroidism, more of calcium is there. This calcium is transferred to fetus, thereby their PTH, because of CSR, calcium sensing receptor, this PTH in them is decreased, and when this baby is delivered, what happens that this calcium is this calcium won't come, and then this child can have tetany because of lower PTH. Okay, so this is a correct. Now coming to option B and D, because these two are slightly controversial here. First, let's see the easy option here. Dexamethasone can be used. This may be a correct option or this may be a wrong option. See why? Because it depends why you are using steroid in pregnancy. What is the indication? Whether you are using it for the fetus or whether you are using it for the mother. If a mother is having some autoimmune condition and you want to give steroid, then you have to give the mother hydrocortisone or prednisolone, because this would be inactivated by placenta and only 10% would reach the baby, the fetus. Okay, it would be inactivated by HSD, hydroxysteroid dehydrogenase. So if that is the reason, then obviously this should be used for mother's autoimmune condition. But if you want to give it to fetus, like say maturity of the lung, all those things, then dexa is something which we give. Okay, betamethasone or dexamethasone, that is to be used. So this option is not absolutely wrong and this is not absolutely correct. Coming to option number B, again this is also very controversial here. TPO antibody will cross the placenta but will not affect the fetus. Okay, so most of the places you will find this line that yes, TPO antibody crosses and it does not affect the fetus directly, but there are studies which shows that in mother who are having recurrent miscarriages, we have seen that those patients who have this TPO antibody, maybe it's totally different, may not be a cause, but they have higher incidence of this TPO antibody. Patients will can have correlation with miscarriages, and the guidelines suggest that you may consider treatment. So this is also not absolutely wrong here. So let's if we want to pick one, then I would pick the answer dexamethasone can be used. This is a wrong option, but it depends obviously, as I have told you. So I think option A, B, C, all these three will consider as correct, and option D is wrong in pregnancy. Dexamethasone can be used, it should not be used in pregnancy. Okay. Coming to question number 19. Dental abscess with pseudofractures with deformity, what is the diagnosis? X-linked hypophosphatemic rickets or Dent's disease. Okay, so let's discuss all this. This is really important here. So X-linked hypophosphatemic rickets, the gene is asked many times. It's FEX gene. Okay, also they have asked many times autosomal recessive hypophosphatemic rickets, also autosomal dominant hypophosphatemic rickets. Autosomal dominant is by FGF23 gene mutation. Okay, and autosomal recessive is by DMP1 and ENPP1 gene. So these two inactivating mutation will cause hypophosphatemic rickets, and here more and more FGF23 we want to be formed, then only hypophosphatemia would be there. So autosomal dominant is by activating mutation of FGF23. Let's talk little bit about FGF23 because many questions are asked from this. So this FGF23, where does it act? It acts on the NAPI co-transporter which are present on PCT of the nephron. So this will cause phosphaturia, thereby decrease phosphate in blood. Hypophosphatemia is caused and thereby causing hypophosphatemic rickets. Okay, so these act on the NAPI receptors, also NAPI co-transporter. Also they inhibit 1-alpha hydroxylase activity, thereby decreasing 125 vitamin D, thereby can decrease calcium. So calcium can be normal or decrease in a patient who have FGF23 dependent hypophosphatemia. Also these are all genetic condition. One important thing is TIO. These have been asked many times. We'll talk more later on. There is question of TIO also. So just tumor induced osteomalacia is also by increased FGF23. Now coming to our question, if question mentions dental abscess, then the answer is X-linked hypophosphatemic Rickets FX gene. That is where you see dental abscess. Okay, so this was the clue in the question. Okay, and okay, we'll talk about Dent's disease also. So Dent's disease is X-linked recessive. It's defect of chloride channel. The gene is CLCN5. Okay, so this is Dent's disease. Okay, coming to question number 20. So, not true about vitamin D3. Calcidiol has a long half-life than calcitriol, less than 15 degree angle for synthesis. 1 microgram equals to 25 international units, or sequesteroid. Okay, so this is actually, see, we know that calcitriol has a very short half-life, around 6 to 8 hours. We have discussed many times. And 25 hydroxy vitamin D have around 2 to 3 weeks. Okay, so this is a correct. And less than 15 degree angle is for synthesis. This I have seen cross-checked. This was not given in the books as such directly. Zenith angle. This is basically the UVB. If they are at less than 15 degree from the ozone layer, they penetrate more through the ozone layer, and thereby it helps in vitamin D synthesis. So if it is more than that 15 degree angle, the synthesis is not that good. Okay, so this is a correct. This is also correct. Sequesteroid, we know that seco is like a Latin term for broken. So yes, it's a sequesteroid. 1 microgram equals to 25 units is a wrong. So not true about vitamin D. Our answer is answer number 3, C. It is equal to 40 international units. 1 microgram of vitamin D is equal to 40 IU. Okay. Coming to question number 21. Maximum triglyceride lowering is by omega-3 phenofibrate statin. Again, this is slightly controversial because various research paper will tell you various things. Most of your data suggests that most of all these drug will lower triglyceride up to 50%. Okay, so we don't have any head-to-head comparison, but yes, some data is there for phenofibrate that it can reduce up to 60%. Omega-3 usually up to 40%, statin up to 30%, but it depends on the dose of the statin what you are using. If you are using very high dose of statin, up to 50% also reduction you can get with triglyceride. Okay, so answer I would prefer here is phenofibrate. Coming to question number 22, renal cell carcinoma with calcium 13 and patient is asymptomatic. Next investigation, what do you want? So renal cell carcinoma, we know that they can have paraneoplastic syndrome and they can release PTH-RP, which can cause hypercalcemia, but still answer I would suggest as PTH calcium phosphate, because you need to follow an algorithm. You need first calcium phosphate, then you need a PTH, then you will label the patient as PTH independent hypercalcemia, and then you will work up for other causes. That is how the algorithm is devised and we have to follow that. So I think a better option, a better answer here would be a PTH calcium phosphate rather than PTH-RP calcium and phosphate. But exact wordings and what the examiner wants, we cannot say. Okay, but I would prefer answer here as A. Question number 23. Fall, fracture, diabetic patient, hypertensive patient with a T-score of at spine minus 2.1, at hip plus 1.8. What is the step to see bone microarchitecture? Do you want an X-ray spine, trabecular scan, or QCT? Okay. So again, this will answer can change just by simple words change. A patient who has fall fracture, that means fracture after trivial trauma. Okay, actually by guideline, even if you don't get a BMD, you can start the treatment, but we need BMD for follow-up, that whether the patient is responding to your treatment or not, that would we have to say. Okay, then these patients have diabetes. Diabetes can cause raise in BMD with a poor quality bone, that is, it can affect the microarchitecture, thereby causing lower quality bone, and still your BMD would be high or normal. Okay, so for that what we usually get is TBS, that is trabecular bone scan. But the question has asked, like if they've asked what is the next step, then you can mark it TBS. Or if they've asked like how do you want to see bone microarchitecture, then what is the best that we want to take, then the answer would be QCT, HRPQCT, high resolution peripheral quantitative CT. Okay, so that is better, but it's like a research tool and you will expose more radiation to your patient. Okay, so what exactly, how the question was formed, answer can be any of these. But if they've directly asked about how to see about bone microarchitecture, then I think QCT would be better. If they've asked that what you do or what is the next step in evaluation of the bone microarchitecture, then the answer can be TBS. Okay, trabecular bone scan. Coming to question number 24, total T4 is high, TSH is normal. Which of the following is not a possibility? OCP, TSH secreting adenoma, thyroxine resistance, and subacute thyroiditis. So this is like easy answer if you know the basic. So with OCP, what will happen? Because estrogen causes TBG to be raised, that is why total T4 would be high. That is how you see in pregnancy, right? The upper cutoff, which is normally 12 microgram per DL, that is increased by 50% up to 18 microgram per DL in pregnancy. Okay, so in OCP use, you will have patients having higher T4 with a normal TSH. Then TSH secreting adenoma, yes, these patients will have higher T4 with a normal TSH. That normal TSH also is abnormal, because in endocrinology everything is dynamic, right? That normal TSH with a high T4 is also abnormally high, right? So we'll have a patient who have normal TSH with a high T4. Okay, so this is correct here. This is also correct here. Thyroxine resistance, yes, we know that depending on the type of resistance, we have read about this, all this. These patients can have a total high T4 with a normal TSH. What about subacute thyroiditis? Possibly this is the correct answer, because rare, very rare instance you may get that. See, for that you must know that what is about this thyroiditis. We have patients who will have first a high T4 as soon as there is inflammation in the gland. This T4 would be high and TSH would suppress. But it is very difficult that you will pick up right at beginning. So initially this T4 will be high and TSH would be low. Classically hyperthyroid patient type of report. Then they will have a 4 weeks of euthyroid, then 4 weeks of hypothyroid, then later on they may revert back to normal or they may be in hypothyroid. So the answer here would be D, but definitely in all these three conditions you can have a high total T4 with a normal TSH. Question number 25, synergistic action on glucose, insulin and growth hormone, obviously not. Growth hormone and adrenaline, ADH and aldosterone. So we know that this is easy. In what happens in hypoglycemia? That is, see, whenever the patient has hypoglycemia, initially the insulin decreases, then the glucagon increases, then the epinephrine increases, and later on cortisol and growth hormone also have this effect. So our answer is growth hormone and adrenaline. These have synergistic action on glucose. You can remember it such a way that when patients have hypoglycemia, this is what the basic physiological changes in the body occurs. Okay, so patient will have this increased epinephrine, increased cortisol, increased growth hormone. This will have action on the same synergistic action on glucose. Okay, coming to question number 26, short stature, brain calcified, deformity with fracture. Okay, so this is slightly tough question here. The answer for this is carbonic anhydrase 2 deficiency. I believe that most of us won't be able to answer this because it is impossible to remember everything. Okay, so this is about osteopetrosis. Okay, osteopetrosis, you know other name, marble bone disease, and Albrecht-Schönberg's disease. This is in adult, slightly less severe form. What is the basic defect? Basic defect is osteoclast bone resorption is defective. Okay. So this is the basic defect here. It can be due to various genes, one of which is carbonic anhydrase type 2. The acidic environment required for the osteoclast to function is not generated because of this enzyme deficiency, and thereby patient develops osteopetrosis. Okay. Also, you must learn at least some basic things like, see, if the osteoclast is not functioning, then this calcium in the blood is actually, there's a balance between bone and this. So when bone cannot be resorbed, so this calcium cannot be transported from the bone to blood. So what will happen? The patient can have hypocalcemia. Okay. Now, since there is no remodeling of the bone because there is no resorption, then what will happen? All the foramen, they will have, there can be narrowing of this foramen. So, these patients can have cranial nerve palsies. Also, since there is no remodeling, the bone marrow would be less because of less marrow space. So these patients can have pancytopenia. So these are some of the important clinical features which you can remember, and also the patients with this carbonic anhydrase type 2 deficiency will have RTA and osteopetrosis. So this is the answer here. Coming to question number 27, what is false about ACC, adrenocortical tumor carcinoma? So CT guided biopsy for diagnosis, 60 to 70% will have hormone production, poor prognosis, and VC score for pathological staging. So this is very easy. We have already discussed about this. And the answer is CT guided biopsy is not at all recommended. In fact, it's contraindicated because you will directly shift the staging, you will disseminate the malignancy. So absolutely FNAC or biopsy is contraindicated in a patient whom you are suspecting an ACC. 60 to 80% produce hormone. Yes, up to 80% of the patients with ACC will produce hormone. 40% will have cortisol excess. 40% will have cortisol plus androgen excess. 10% will have androgen excess. So once it was asked which is least likely, then the primary hyperaldo with ACC is very, very rare. Okay. So this is very rare. Okay. Poor prognosis, yes. VC score for pathological staging, yes. So we see their mitotic rate, necrosis, capsule invasion, venous invasion, all those things. Yes, VC score is used. Okay, so these three are correct. This is absolutely wrong here. ACC, we should never do any FNAC or CT guided biopsy of the adrenals. That's absolute contraindication. Okay, coming to question number 28, prolactin with 35 nanogram per ml, which is not a possibility, microadenoma, macroadenoma, drug, or just a stock compression. Okay, so we have also discussed this when we are discussing pituitary. Prolactin level may help you to guide about what is the diagnosis. So if prolactin level is between say somewhere around 25 to 100, they can be drugs or just primary hypothyroidism or macroprolactinemia. Okay, and 100 to 250 will be microprolactinoma, but 25-30% of the patient will have less than 100. Macroprolactinomas will have a very high level of prolactin, but again, due to hook effect, you may get normal or falsely low reports as well. So this is important. So in clinical practice, we get in dilution, but if just the report is there 35, then you cannot rule out that these patients cannot have macroadenoma. They can still have macroadenoma due to hook effect, but for your answer, obviously will tick as macroadenoma. It is very unlikely. Microadenoma, yes, a possibility. Drug, yes, obviously a possibility. Stroke compression, obviously a possibility. Macroadenoma, though a possibility, but very rare with this type of prolactin. Just to complete our discussion, I'll tell you about hook effect. That is very, very important for clinical practice, also for your MCQ. What happens here? You see, you have a solid phase capture antibody where whatever antigen you are detecting, say TSH, prolactin, or whatever antigen, whatever you want to measure in blood, whatever assay you are using, that will stick to that antibody. That is the capture antibody. This is what you want to detect, the antigen. And then there is a labeled antibody. This antibody will form a sandwich with this antigen, and this is labeled with some detection thing which we use to pick up. Okay, this is used for picking up what is the concentration of that antigen what we are using. Okay, so what happens in macroprolactinoma, the prolactin is very, very high. So this sandwich is actually not formed. So we get false negative result. The prolactin is so high that this prolactin will bind to this solid phase, will also bind to this labeled antibody, but when you will wash, there is no chelation. But once you dilute it, you reduce the concentration of this, then absolute like this would be there, that the capture antibody will be attached to a prolactin and one labeled antibody will also be there. Okay, and this you can pick up on your assay. So absolute this sandwich would be formed. Then there are also false positive result. This is about macroprolactin. What is macroprolactin? Macroprolactin is nothing. It is just that some, especially IgG antibody, is chelated to this prolactin, and since this is now a bigger molecule, this is not excreted via kidney. Okay, so it will remain in your blood but will not be biologically active. So this prolactin will be picked up by your this labeled antibody and this solid phase capture antibody, and you will have false positive result. But this macroprolactin is biologically inactive prolactin. Okay, so these two important concepts I want to tell you here. Okay, question number 29. Female with weight gain with weakness since 2 months, basal cortisol not detected. What is next step? She has exogenous Cushing's. You want to repeat the basal cortisol after 3 days, or you want a urinary cortisol. Okay, so what the guideline says, this is I've taken from Harrison. Though in this chart you may not see a basal cortisol, but when you will read the text, they have written to rule out exogenous Cushing's. This is from again JCM guideline 2008, which we follow. See, if you have a patient with suspected Cushing's, first and foremost important thing is to rule out exogenous glucocorticoid exposure. Though the guideline usually says by history, but we obviously get 8 am cortisol, that is basal cortisol. Okay, so if this is low, definitely it is an exogenous Cushing with secondary adrenal insufficiency, right? So you don't need to proceed further. You can just label the patient exogenous Cushing's. You don't need any other test now. Okay, so first and important thing is 8 am cortisol, and once this is normal or high, just by 8 a.m. cortisol value, you cannot say that this patient has Cushing's. This is to rule out exogenous Cushing's. Then you perform a screening test, whether you get any of the, you get any 2 tests of the 3. Okay. So you need either 24-hour urinary free cortisol, ONDST, overnight dexamethasone suppression test, or late night salivary cortisol. These also needs 2 tests should be done. And then you can proceed for LDDST, low dose dexamethasone suppression test. And once you have confirmed that it is Cushing's, then the most important thing is you need ACTH values. If ACTH is more than 15, then it is ACTH dependent Cushing, and if it is less than 5, then it is ACTH independent Cushing's, and accordingly you will further work up. For ACTH dependent Cushing, you will get an MRI, because the Cushing's disease is the most common cause of ACTH dependent Cushing syndrome. Okay. So coming to question number 13, 56-year-old male with resistant hypertension with hyperaldosteronism diagnosed and 1.8 centimeter nodule in adrenal. What is your next step? Do you want to start with spironolactone? You want to go for adrenal venous sampling, or you want unilateral laparoscopic adrenalectomy? So this is very relevant question here. Start spironolactone? Obviously not. If you want to start spironolactone, why did you evaluate all this? So obviously the answer would be between AVS or adrenalectomy. So for this you must know the guideline. First of all, now the latest edition of Williams says that almost like they've written that every hypertensive patient should be evaluated for primary hyperaldosteronism. Previously we have cut off that resistant hypertension, hypokalemia, all those patients young hypertension should be evaluated for this primary hyperaldo. So for that, what does the guideline suggest? So those who are at increased risk of primary hyperaldosteronism, initially we need to screen with ARR. All those patients we have to screen with ARR, and even before anything evaluating about this primary hyperaldo, you must talk to your patient and let them understand that what are you going to do, and these evaluation take lot of money and time. Secondly, even after this diagnosis may not be certain and the patient may have a bilateral disease, so then you need to start the same drug which you can give it now itself. So that the patient must understand. But why are we then doing all these things? Because even with controlled hypertension, a patient who have high aldosterone will have poor cardiac outcome. That is why not just hypertension, even controlled hypertension with hyperaldosteronism will have a poor cardiac outcome, right? They have increased risk of fibrosis and heart failure, arrhythmias, right? So this is important. So if the patient is unwilling for surgery, then please don't evaluate, because then why are you evaluating? What will happen after making diagnosis, right? So ARR, if suggestive of primary hyperaldosteronism, then you need a confirmatory test. But there is clinical condition where you don't need any confirmatory test, like if patient have hypokalemia with decreased renin and aldosterone more than 20 nanogram per dl, then you can skip the next step of confirmation and you can proceed for imaging. But if this criteria is not satisfied, all those ARR, and the cutoff of ARR also depends on what unit you are using for aldo and renin, right? So that ARR cutoff, if met, then you need a confirmatory test, and if that is positive, then you need an imaging to localize the lesion. If the lesion is unilateral, you cannot go directly for adrenalectomy. Why? Because see, there is cutoff where you can directly go for surgery in patient with marked primary hyperaldo with young age and unilateral lesion, right? So this young age is very important here. The cutoff given is 35 years. If the patient is less than 35 years, you can directly go for surgery and you don't need an AVS. Why you need an AVS beyond 35 years? That's very simple. Because as an age your patient is aging, the risk of adrenal incidentoma is increasing. So your patient may have a right-sided primary hyperaldosteronism and he may have an incidentoma on the left side. So when you are doing an imaging, maybe this adrenal incidentoma is detected and there is no lesion on the right side where actually the hormone is being secreted, right? So you will operate him on the wrong side. So that is very important. So all those patients must undergo AVS, adrenal venous sampling, and if that doesn't localize, like doesn't lateralize the lesion, then medical management should be done. If that is lateralized, then you will go for surgery. So this is important, and even next level question can be asked where they'll give you values for aldosterone and they'll give you values for cortisol, and they can give you an AVS and ask you to interpret. So please go through our question discussion, question number 28, right, where everything we have discussed in detail, all the clinical scenarios, what is lateralization index, what is sensitivity, all those, everything we have discussed. Selectivity index, lateralization index, contralateral index, ipsilateral index, all those things we have discussed. Okay, so here you have 1.8 centimeter nodule, but the age, that is what is defining our answer here, AVS. So for a 56-year-old male, even with a unilateral adenoma with a primary hyperaldosteronism, you need an AVS to confirm that that is the lesion from where the hormone is secreted. That is important. Okay, so this is guideline based answer. Okay, question number 31. T score at spine is -2.1, at hip is -1. So what is the diagnosis? Is it normal, osteopenia, osteosclerosis, or osteoporosis? So very easy here. So if 50 male more than 50 years or postmenopausal woman, okay, there you use T score, and if the T score is better than -1, it is normal. -1 to -2.5 is osteopenia, and lesser than -2.5, say -3.54, all those are osteoporosis. But for a young person we use Z score, right? And Z score, if less than -2, we say that the patient have low BMD, and if it is better than -2, say -1.5, -1, anything like that, so that is normal BMD. Okay, better than -2 is normal, worse than -2, that is more minus, then it is low BMD in Z score, and this is for T score. So here they have given T score, though they have not given the age of the patient. So obviously we do understand that they are using the T score. So probably they are dealing with some postmenopausal woman. So answer for this, as the higher value is -2.1, will take as osteopenia. Okay. Coming to our next question. Okay. Question number 32. Hyperparathyroidism with Wilms tumor. Which gene is involved? So this is direct answer here. The answer is CDC73 gene is involved. So what is this? What are they talking about? They are talking about hyperparathyroidism jaw tumor syndrome, which is autosomal dominant, which is due to CDC73 gene defect, HPRT2, right? And it's an autosomal dominant condition. What does this gene produce? This produces parafibromin, right? And this parafibromin, this decreases cell growth. So inactivating mutation, this was also once asked. They have given activating mutation, and the answer was that that is the wrong option, because it is an inactivating mutation. Because when there is inactivating mutation, this parafibromin will decrease and this cell growth will increase. So they will have multiple tumors. One of them is Wilms tumor. Then regarding the hyperparathyroidism, they have multiglandular disease. This was asked. Then they have uterine fibroma. They have polycystic renal disease. And one more important question was asked, that how many of them have parathyroid carcinoma, because it's very rare sort of thing. So 15% of these patients will have parathyroid carcinoma. This was asked directly in one question exam. And multiglandular disease is asked, autosomal dominant, parafibromin, CDC 73, HPRT2. All these have been asked previously, and Wilms tumor is also asked. Okay. Coming to question number 33, men syndrome with LIPA, that is left inferior parathyroid adenoma. What do you want to do? Do you want to do a total parathyroidectomy with thymectomy with autonomous implant? You want a subtotal surgery, or only left inferior parathyroid do you want to resect? Okay, so when you will read Harrison, what is the treatment, then they have not clear-cut mentioned that this should be done. They've given all the options, and it is usually the institutional procedure that what they want to do, they do. Okay, but the guideline clearly indicates that all these patients with men syndrome, because there is higher risk of multiglandular disease, also chances of relapse. So what they do is they explore all the gland, and subtotal parathyroidectomy is what is indicated in men syndrome, patients with hyperparathyroidism in men syndrome. So answer will take here as subtotal. Okay, but if you will go by just Harrison, then you may not be getting it right. Okay, question number 34. This question actually we could not get a complete recall. Something bilateral periarticular was written. FGF 23 we have discussed in great details that what it does do, NAPI and all those phosphaturia, everything, any TIO will be discussing, everything we have seen, right? Klotho is co-receptor of FGF 23. This was asked previously. Gallant3 mutation is for tumoral calcinosis. Here see, in FGF 23 when it's raised, it causes phosphate to be decreased because it is causing phosphaturia. But when there is this mutation actually decreases, Gallant3 mutation decreases FGF 23. So this phosphate is raised, and because of this raising of phosphate, there are various calcifications. Okay, so this is Gallant3 mutation. Okay, coming to our question number 35, amiodarone induced thyrotoxicosis. What is false? So we have discussed this many times ago for this AIT. This is very important topic. Option given here are AIT1 is due to destructive thyroiditis, amiodarone given for arrhythmias, but they may worsen after AIT. AIT1 requires anti-thyroid drug, and AIT2 requires steroids. And fourth is UHG can differentiate between them. Okay, so for this, obviously you cannot remember everything, you have to understand, then only you will be able to solve this question. So just remember one line, you will be able to solve all these questions. AIT1 is something where the thyroid is abnormal from beginning, 1 previously, 2 it's absolutely normal, now something is happening. Okay, so in 1, underlying thyroid abnormality is there, and they have autoantibody positive. So autoantibody is positive. Now what is happening? You have given them amiodarone. This question was asked that how much it contains iodine. It contains 37%. Okay, 37% weight by weight iodine is present in amiodarone. This is asked many times. Okay, so now what you are giving? You are giving them iodine. So what will happen? That this gland will form more and more hormone because there is some autoimmune condition previously, right? So they will have high vascularity, which you can pick on color Doppler, and you need anti-thyroid drug because now this gland is forming more hormone, and you have to discontinue amiodarone, and there won't be any spontaneous remission of this condition. Okay, so this is what is AIT type 1. Okay, now coming to this part, what about the radioiodine uptake? So this is very, very important here. Now you would say, okay, this gland is forming more, so the uptake should be high. That is what is the basic concept. But here you can get a low or normal uptake. Why? See, what is happening, because you have given so much of iodine to the patient that the gland is saturated now. So when you are giving this radioiodine uptake, because the gland is already full of iodine, it will not pick up. So you may get low iodine uptake on the scan. That is important. Now coming to AIT type 2. So this amiodarone induced thyrotoxicosis type 2, as I have told, no previously it was normal, antibody is not there, right? And now what happened, it is more of a thyroiditis type. This is what hormone is released, is a preformed hormone. So they will have a decreased vascularity, obviously uptake would be less, and because it is a thyroiditis type of picture, you have to give prednisolone. Don't give the anti-thyroid drug, carbimazole, methimazole, these are not to be given here, okay? And they usually resolve spontaneously, they go into remission, and you may even continue amiodarone after that. So this is important here. Okay, coming back to our question. So AIT1 is due to destructive thyroiditis. Absolutely, this is wrong here, because one is preformed autoantibodies are there, and this is not a thyroiditis type. This is type 2 which have thyroiditis picture. Then second, arrhythmia may worsen if the patient develop AIT. Obviously it can worsen. AIT requires antithyroid. Now we know that. AIT2 requires steroid. We know that. UHG can differentiate. Yes, color Doppler can differentiate, because in one gland would be hyper functioning and will have a higher flow. The color Doppler will show increased vascularity, but in type 2 it's a thyroiditis type, so vascularity would be decreased. Okay, coming to question number 36, not used for TIO. Okay, see, TIO we have discussed a little bit when I was discussing about VDDR. Sorry, not VDDR, about the FGF23 and all X-linked hypophosphatemic rickets. So TIO is by mesenchymal tumor. Okay, so this mesenchymal tumor, what they do is they secrete this FGF23. They form this FGF23 and the phosphate is low, right? So phosphate is low, so you have to give them phosphate. And I have told you that this also inhibit 1-alpha hydroxylase. So this 1-alpha hydroxylase is inhibited, that is why 125 vitamin D is less, and you have to give that. Surgery is obviously the treatment of choice, because this is FGF23 is produced by a tumor, usually in the periphery, say appendages, in the foot, in the hand, somewhere like that it is produced. So this tumor is really difficult to pick up, and we do PET scan and Dotanoc, gallium scan, we do that. So surgery is the mainstay, the main treatment. Lasix obviously you don't want to give, because this will further deplete the phosphorus, and already phosphorus is low. That is why these patients have bony pain and all those symptoms, myopathy. So you cannot give Lasix. So that is the answer here. Okay, so coming to question number 37, not used in subacute thyroiditis. Now this is pretty easy. After AIT you must have known this answer. You don't want to give antithyroid, glucocorticoid, NSAID, beta blocker. So obviously thyroiditis, the gland is not forming more hormone, it's the preformed hormone which is released, so no role of antithyroid drug. In fact, if you're giving these antithyroid drug, what you're doing, you are prolonging the duration of hypothyroidism. See, there is a phase. The patient have a toxic phase, then a euthyroid phase, then a hypothyroid phase, which may go into recovery or may be having permanent hypothyroid. So usually we remember like this: 4-week hyperthyroid, 4-week euthyroid, then 4 weeks hypothyroid, right? So if you are giving this drug in hyperthyroid phase, you're prolonging that hypothyroid phase. So ideally these patients should not be given antithyroid drug. What should be given is just high dose aspirin or NSAID. If still the patient has pain, has symptoms, then you may give them glucocorticoid. Otherwise, even glucocorticoid is not given practically, we just give NSAIDs and beta blocker. Beta blocker, why they are given? Because this will help them symptomatically. All those tachycardia, palpitation, what the patient is having, that will be benefited. Also, this T4 to T3 conversion is inhibited by beta blocker. So that is again very important. This will help our patient. So beta blocker we do give, NSAID we do give, glucocorticoid is also given, but anti-thyroid drug is not to be given in subacute thyroiditis. This graph you must have seen. It's seen in various time. Okay. Coming to question number 38, SERMs false is, that is selective estrogen receptor modulator. What is false regarding that? So tamoxifen for female precocious puberty for McCune-Albright syndrome. Tamoxifen is FDA approved for gynecomastia. Raloxifene is antagonist on uterus, and raloxifene is for osteoporosis. Okay. So this is very important question. Yes, tamoxifen can be used for precocious puberty of McCune-Albright syndrome, but it's not an FDA approval for that. But yes, it is a correct here. Tamoxifen is approved for gynecomastia? No, it is not approved for gynecomastia. It is approved for breast carcinoma. So the false statement is this. Yes, raloxifene is antagonist on uterus. A better is endometrium. Okay, and raloxifene can be used for osteoporosis. Yes, it is FDA approved for this. So these three statements are correct, and our answer is this one, that tamoxifen is not FDA approved for gynecomastia. Yes, but we do use for gynecomastia 10 to 20 mg. We do give them. We should look for hepatic dysfunction in those patients. And also for this osteoporosis, raloxifene, one more important thing I'll tell you, that it reduces fracture risk of vertebral fracture risk. But question mark on non-vertebral fracture risk reduction. Okay, so this is important. And also regarding tamoxifen and raloxifene, raloxifene is antagonist on endometrium, whereas tamoxifen is agonist. So these difference is very important. Tamoxifen and raloxifene for bone, both are agonist. Okay, for breast both are antagonists, but for endometrium raloxifene is antagonist, whereas tamoxifen is agonist. That is how it is, selective estrogen receptor modulator. It acts somewhere agonist, somewhere as antagonist. So this is important. This has been asked in various exams. Okay, coming to question number 39, which is not due to enzyme deficiency, galactosemia, FHH, familial chylomicronemia, or same, that is syndrome of apparent mineralocorticoid excess. So almost everything we have discussed in great detail. So this galactosemia, this is basically an enzyme defect, right? This is by galactose 1 phosphate uridyl transferase. So this is the defect. Gene is Gold gene. Familial chylomicronemia, we know that this is due to defect in LPL, lipoprotein lipase. This is autosomal recessive. Also, it is due to one more defect, that is ApoC2 deficiency. This is cofactor for the LPL. Okay, so ApoC2 deficiency will also cause familial chylomicronemia. Syndrome of apparent mineralocorticoid excess, we know that cortisol is converted to cortisone, that is inactivated by 11 beta hydroxysteroid dehydrogenase type 2. Okay, so this is important. And when there is defect in this gene, what will happen, that cortisol will not be inactivated, cortisol would be high and will act on mineralocorticoid receptors. So it will act like aldosterone. Here we'll have low aldo, low renin, hypocalemic hypertension, right? You understand the basic. This cortisol is acting on the mineralocorticoid receptor. It's not being inactivated, so it is acting like aldosterone, but when you will test for aldosterone, it will come low, but it is acting like mineralocorticoid. That is why renin will also be low. So it's a hyporenemic hypoaldosteronism, right? This is very important. Hyporenemic hypoaldosteronism, syndrome of apparent mineralocorticoid excess. Coming to FHH, this is again very important topic. Familial hypocalciuric hypercalcemia. Okay, that means hypercalcemia means in blood you have more calcium. Hypocalciuric means in urine you have less of calcium. It's a familial disease. Okay, there are various genes. The most common is CSR gene. Okay, other than that is first is CSR gene, second is alpha subunit of G11. This is something downstream pathway of CSR. Then adapter protein AP2S1. So these all gene defect can cause FHH. Since you don't have calcium in the blood, calcium in urine, these patients won't have renal calculus. And in clinical feature are usually these patients are asymptomatic, picked up during testing. As more and more tests are being done, you will pick up that these patients have hypercalcemia and will have a family history. Very important, they will have a low hypocalciuria. So calcium creatinine ratio, that is very important, that is less than 0.01. This has been asked many times. And know the basic, what is happening here. There is mutation in CSR. What does this CSR do? Whenever in blood you have higher calcium, right, this CSR will sense the ionic calcium and will decrease the PTH. But now what is happening, either this CSR is not functioning or is having less sensitivity. This adapter protein, if defective, this will have a less sensitivity, so this will be inhibited at a higher concentration. So this is not sensing this calcium, and so this PTH won't be decreased, PTH would be high. That is why this is a PTH dependent hypercalcemia. So this is very important. This is PTH dependent hypercalcemia. It's an autosomal dominant condition, and the basic defect is in CSR and the ratio. These all questions have been asked in previous exams. Okay, question number 40, estrogen in Turner, when to start? Okay, so 7 to 8 years, 11 to 12 years, after 14 years, the guideline says beyond 11 years, so 11, 12 years. This I have taken from Sperling. You will see here that if no spontaneous development and FSH is elevated by 12 to 13 year, you have to start the estrogen supplementation. So one more important thing, up to 10 to 30% of this Turner syndrome will have spontaneous puberty. Those patients who don't enter into puberty, we should give them estrogen by 11 to 12 years. There are two methods, either you can give by oral or transdermal patch. Transdermal patch, which comes by the name of Estradum, these are usually two strength, 50 and 100 microgram. What we do is we divide this patch into 8, this one patch of 50 microgram, and we ask them to replace it daily. Orally, what we give them is Velred, that is Proganova, which comes as 2 mg, but we want to give them 0.25 mg per day. So what we do practically is we divide this 2 mg tablet into 4, that is 0.5 mg would be there, and then we give them this alternate day, and we increase the dose every 6 monthly. We have to develop this puberty over 3 years. So we gradually build up the dose of estrogen over 6 monthly, right? So this is how we do it. Okay, gene for 25 hydroxylation of liver, question number 41. We know that it's 2R1. We have seen in VDDR just now we have discussed. So gene for 25 hydroxylation in liver is 2R1, and if this is defective, we have VDDR type 1B. Okay. Question number 42. Which can be used for achlorhydria? Which calcium preparation? Do you want to use citrate, carbonate, lactate? Okay. Or gluconate. So, see, this again can be slightly modified as per the wording in the question. I'll tell you how. See, in carbonate, we have 40% of elemental calcium. In citrate, we have 20 to 21% of elemental calcium. Lactate, we have 13% of calcium. And gluconate, calcium gluconate, we have 9% of elemental calcium. So these two, though their solubility is very good, but they are not very useful because the elemental calcium is less. So usually we don't use this. Achlorhydria will definitely impair the absorption of carbonate and will not impair the absorption of citrate. So answer here I think should be calcium citrate should be given to a patient, but if the question is which of them have a higher solubility index or like which will be better absorbed, then the answer would change. Solubility is better for these, but practically because their elemental calcium is very less, we want to give them calcium citrate. So which can be used in achlorhydria, whether they want a patient, that in patient what do you give, or which is best which is best for absorption in achlorhydria, the answer would change. So exact wordings we need for this. Coming to question number 43, false about cabergoline, used in both acromegaly and prolactinoma, contraindicated in fibrotic disorder, not to be used in lactation, increases radiotherapy sensitivity for Cushing syndrome. Okay, so we know that cabergoline is usually given for prolactinoma, and this will inhibit lactation. So if the patient have prolactinoma and have gone throughout the pregnancy without cabergoline, then we usually don't give in lactation, and it's like in contraindication for contraindicated in lactation. Okay, contraindicated in fibrotic disorders. Actually in lactation it's not contraindicated, but it should not be given. Then contraindicated in fibrotic disorder, we know that right-sided valvular fibrosis, valvular lesion do occur with this cabergoline. So yes, it is contraindicated in fibrotic disorder. Can be used in acromegaly and prolactinoma? Yes, prolactinoma surely we do use them. In acromegaly and Cushing's also we use them, and in acromegaly even single use monotherapy of cabergoline have shown to reduce IGF-1. So yes, we use them, but they are not the first line treatment for acromegaly patients. Okay, increases radiotherapy sensitivity. In fact, they decrease the radiotherapy sensitivity. The chances of recurrence of tumor in a patient who has taken cabergoline is higher. So this actually decreases the radiotherapy sensitivity. So this is the answer, false about cabergoline, because it decreases the radiotherapy sensitivity. Okay. Question number 44. Menstrual cycle is ultradian, infradian, circadian. So this is a very basic question here. You should know, like circadian and diurnal is almost same. It is a rhythm which oscillates for 24 hours. Okay. So this is about a day, this is exactly day, but in day to day we use it interchangeably. Circadian rhythm and diurnal rhythm practically are the same thing. Ultradian is less than a day, like say for example a person entering into puberty, so GnRH is secreted in pulse during night, right? So that's an example of ultradian rhythm. Infradian rhythm is longer than a day, which is a menstrual cycle, right? Then range is different between the highest and the lowest, trough and the peak difference. Nadir we know obviously the lowest. Acrophase is the time at which that hormone is peaking, right? Very important. Zitziberg has been asked many times. This is what gives the signal to the body to have this rhythm. That is that signal. So time given, the external clue Okay, this is Zitziberg. This has been asked many times. Okay. Coming to question number 45. There was a picture of meant to be mucosal neuroma on the tongue and lip, and which is not seen. Diarrhea, retinal angioma, intestinal ganglioneuroma. We don't have here exact question, but probably the answer is diarrhea, because these patients have megacolon. They usually have constipation, not the diarrhea. Retinal angioma are actually basically associated more with VHL. Okay, so these question we have also covered, and this chart is from Harrison. You have to remember each and every one. Even the percentage have been asked in various exam, like what is the most common, how many percentage will have pheochromocytoma in men to, everything has been asked. So this is useless to discuss here. You have to remember all these facts as such. Okay, they've asked question about meant to be. They have mucosal neuromas. This photo I have taken from Aaron Institute, SGPGI. So here you can see that the patient have mucosal neuroma. This was a patient of meant to be. Okay, they have marphenoid habitus. They have medullated corneal nerve. They have megacolon. So they have this constipation. Now diarrhea would be the answer here, but other option we have to see. Frax does not include. Okay, so this question is also important. See, the option which we could get in recall are both wrong here. Actually, steroid duration is not included. It is the use, not the duration and the dose. Bone markers are absolutely not in the Frax score. So preferred answer would be bone formation markers. We have discussed this Frax score in previous question also when I was discussing bone. So it includes age, sex, weight, height, previous fracture in family, like parents. So this is important. Is smoking, glucocorticoid. It is whether it is used or not. Dose duration is not there. Then rheumatoid arthritis, secondary causes of osteoporosis, alcohol, and BMD. BMD, hip, and specifically femoral neck BMD is to be used. If the patient is diabetic, then we may take this rheumatoid arthritis as yes, or as secondary osteoporosis as yes. Any of the one. Okay, so this is a modification in the fracture score, because in diabetic patient the BMD may increase. Still they may have increased risk of fractures because the microarchitecture is defective. The bone quality is not that good. Okay, coming to question number 47. Disproportionate short stature. X-ray shows non-fusion of pelvic bone. Which of the following is not true? Exact question we don't have. Probably they are talking about achondroplasia. Please read all the genes, because this is a very big topic. Here GH given is actually, they can be given, growth hormone can be given, but usually it is not given and it's not an approved indication. Mesomelic dwarf is wrong. They are rhizomelic. Narrow foramen magnum is correct. But exactly whether this question was about achondroplasia or not, I cannot say. We want more details regarding the question. Okay. So I am not covering this in much detail here. Okay. Coming to question number 48. Osteogenesis imperfecta, which is false. So type 4 collagen is involved, bisphosphonate is contraindicated, hearing loss in type 1 of osteogenesis imperfecta, and blue sclera in type 2. Okay, so this is easy. Yes, they have blue sclera in type 1, type 2, hearing loss in type 1. Yes, bisphosphonate contraindicated is absolutely wrong, because this is the mainstay of treatment. We do give these children bisphosphonate. Type collagen 4, actually it is type 1 collagen which is involved in I've told you how to remember, like bone 1, it is already written in bone 1, right? Then you can remember, like cartilage is cartilage, it's 2, right? Reticulin, reticulate is reticulate, like that you can remember. And okay, so bone 1 is there. It is mainly the type 1 collagen which is involved, but yes, there are genes in osteogenesis imperfecta where collagen processing is defective, in which other collagen may be affected. So these we can consider as yes, type 4 collagen can be involved, but when I was searching for this option, I could not get directly. But probably the answer here is bisphosphonate contraindicated, because they are the mainstay of treatment. So bisphosphonate is not at all contraindicated. Okay. Coming to second last question number 49. Parathyroid develops from which pouch? Okay. So this also we have discussed in question number first of bone. Okay. So this parathyroid, we know first important question is they are endodermal. These have been asked. They develop from the third and fourth pharyngeal pouch. So from the third develops the inferior parathyroid, from the fourth develop the superior parathyroid. And this third pharyngeal pouch is slightly higher up. So this third, this inferior parathyroid have to descend more. Okay, they have to descend more. So what happened? They are more ectopic. These have been asked many times. These have been asked. This is endodermal. They origin from third and fourth pharyngeal pouch, and more ectopic is with inferior parathyroid gland than the superior. And also they have asked most common location. Most common location is intrathyroidal. So most common ectopic parathyroid gland are inferior parathyroid gland, which are intrathyroidal. All these MCQs have been asked. Okay, coming to our last question of discussion. RAIU, radioiodine uptake, is increased with excess of iodine, TSS secreting pituitary adenoma, Hamburger's thyrotoxicosis, or exogenous T4. So this is very easy question here. You just know the basic, that what you are picking up in radioiodine uptake. Basically you are giving a radioiodine labeled iodine, and that is picked up by the scan when it is concentrated in the thyroid. Okay, so when you have already given excess of iodine from outside, the scan, whatever radioiodine you are giving, that won't be concentrating in thyroid. So this will have a decreased radioiodine uptake. Hamburger thyrotoxicosis is that meat, especially thyroid, is thyroid of the bovine thyroid is ingested. So these patients may have thyrotoxicosis. So when this is just like an exogenous thyrotoxicosis, this is not hyper functioning of the gland, so uptake would be less. Exogenous T4, obviously when you are giving from outside, the inside mechanism would be shut down, so they would have less uptake. The answer here is TSH secreting pituitary adenoma. In this pituitary adenoma, TSH would be high or normal. This will give signal to the thyroid to actually form more of T4. This is a hyperthyroidism. Okay. So this is thyroid uptake taken chart from Williams' latest edition. Increased hormone synthesis. Wherever there is increased hormone synthesis, you will get an increased uptake. So hyperthyroidism, Graves, you will get that. And recovery after suppression, obviously you will get recovery from thyroiditis. Acute phase of thyroiditis will have decreased uptake, but in recovery phase, they will have a higher uptake. Okay. Then after depletion, this is recovery from anti-thyroid agent. If you will stop immediately, then you can get an increased uptake, but with anti-thyroid agents, you will have a decreased uptake. Then if there is excess of hormonal loss like the nephrotic syndrome, then patient will have more formation of this hormone because they are losing in urine, right? So they will have an increased uptake. Okay. Then which of the factors decrease uptake? Hypofunctioning, like primary hypothyroid, when you are giving them drugs, anti-thyroid drug, any defect, Hashimoto's disease, thyroiditis, all these will have an exogenous thyroid hormone. These will have decreased uptake. So this is just, you can remember by basic mechanism. You don't have to remember all the names. So this is the end of our discussion. If you have any doubt, you can send us a mail. We'll be very happy to answer your question. Thank you.